Welcome everyone to this exciting and new event. This is the next episode of the Journal of Clinical Anesthesia monthly podcast, where we feature noteworthy articles from each issue. I'm student Dr. Ashley Moore, assistant social media editor for the Journal, and your host for today's interview. I would like to offer a huge welcome to Dr. Kamal Maheshwari in the Department of Outcomes Research in Cleveland Clinic, Cleveland, Ohio, and the Department of General Anesthesiology in Cleveland Clinic, Cleveland, Ohio. He is one of the authors of an article from our upcoming May 2024 issue titled Development and Validation of Delirium Prediction Models for Non-Cardiac Surgery Patients. Thank you so much for taking the time to speak with me today.
Thank you for having me.
Great. So we will go ahead and get things rolling and start off this interview by asking, could you quickly summarize your study for our listeners?
Yeah, a few things. First of all, this is a great venue to discuss the research findings. So thanks for doing it. And all the best to you for your future endeavors. And one other thing is this research was done when I was at Cleveland Clinic. In the last 6 months, I changed the job also. So just for the viewers to know. Yeah, so regarding this research, so my research is mostly focused on outcomes, how outcomes can be improved. And a lot of work was done as how hemodynamic variables, especially blood pressure, cardiac output, can affect outcomes after the surgery, right? So mostly we studied outcomes, myocardial injury, kidney injury, infections, because these are the outcomes which are readily available because the biomarkers were readily available or the data was readily available. And we did both retrospective studies and clinical trials, right? And if you think about it, we are looking into that what can be done during the surgery or in perioperative period, right, to improve patients' outcomes. And outcomes are related to organs, and organs, myocardial injuries for heart, kidney injury for kidney, right? So that's logical. One of the things which is brain injury is very poorly defined. And in the brain injury, we are, during anesthesia, giving anesthetic drugs affecting brain perfusion. And what is the effect of anesthetics and how can we improve the brain outcomes, right? And what is the brain outcomes, brain-related outcomes are? So recently, they come as a spectrum of neurocognitive disorders, right? In which delayed emergence, delirium, and postoperative cognitive dysfunction. This has been highlighted as a big burden on the patients after the surgery, right? And very limited data is available regarding these. And most of the data is coming from cardiac surgery setting. So our research is in the non-cardiac surgery setting where most of the surgeries are happening. We said that how do we assess the effect of perioperative interventions on brain, and we picked up delirium there, right? So delirium is very common, widely reported, and very varied outcome incidence from like 5 to 50%. And so that was a little bit concerning to me, and that's how this question started, right? That how can we study, quote unquote, brain injury, right? And we said, like, let's start with delirium. And we were fortunate in Cleveland Clinic that in the last 4 or 5 years, a routine assessment of delirium, which is through confusion assessment method, was started, and on the hospital wards or floors, And that data was available. We looked into it, and so there was some time to understand, if we have that information in a good format. And once we knew that in a good format, that was a good start for us to assess. So that was the start of that. Okay, we want to study delirium as an outcome, an effect of perioperative interventions. Now comes the question is that which patients are more likely to get delirium, right? And then when we looked into it, there were multiple methods of assessment of delirium. As I mentioned, CAM is one of them. But according to American Delirium Society, there are more than 30 different screening methods for delirium, right? And which patient are likely to get into delirium? Also, again, there are multiple risk factors, and recently multiple predisposing and precipitating factors were defined, right? But it was still not clear that which factors were more important than others, right? So in research and in machine learning research or data research, you can say which features means which parameters are more important in causing delirium, right? So those were the multiple questions which were there, right, in devising the study. And we said that, okay, can we develop a good prediction model for delirium now that we have enough data, right, both on the outcome side and on the side of like what are the exposure variable which can be, which are well defined from research, right? And we'll say, okay, we start with that, and then build on that basic foundation and move on to do clinical trials, because in clinical trials you have to figure out high risk patients and then work from that. So that was the whole idea why we devised the study and looked into a delirium prediction model.
I love that. That is fantastic, and it's so fascinating to hear you talk on that. Can you tell me, so I know you chose like a rather broad population to build your prediction models from. Could you explain why you chose that specific population, and how does this population differ from previous studies on delirium prediction models?
Yeah, and so that's a good question. As I briefly alluded to, the data regarding the incidence of delirium or the disease burden of delirium in perioperative setting is mostly coming from cardiac surgery, right? On pump or off pump surgeries, and limited data was available because there's no generalized or routine delirium screening, right? So if you don't screen the patient, you would not know, and then you cannot tell, right? That you cannot predict or even make any intervention to kind of correct things, right? And so in non-cardiac surgery, which is more than, I think, 300 million, last time you could quote surgeries which happens, there's very limited data regarding, because the delirium screening is not routine, right? And you cannot capture it. So that's why, in studies, when you start devising even clinical trials, you start broad and then slowly narrow it down. So because it's a start, we started with the broader population of non-cardiac surgery to assess the burden of delirium, right? As I said, the range was up to 50%. And then we hypothesized that, in non-cardiac surgery, the patients are not as sick. They're not going for long surgeries. And that delirium risk should not be as higher as the cardiac surgery patients. So that's why we chose a broader patient population. And I think the future study can focus on, a much narrower population going forward. But at the starting point, we had to choose a little bit broader, non-cardiac surgery.
That makes complete sense. So I was wondering, can you also elaborate on the rationale behind building both static and dynamic prediction models for postoperative delirium. And then also tell me, what advantages do dynamic models offer over static models and vice versa in terms of the context of your study?
Yeah, I think that is the most interesting part of the study, and which we went back and forth with our, smart statistical team. I remember having multiple discussions with Karan, who's the lead statistician on this thing, and other people, right? Um, and that is always exciting part when you have to go back and forth. That is not defined yet. So the reason we chose different type of models, static and dynamic, was multiple, and I'll start with one of them. So first of all, delirium, as I talked about, there's a predisposing factor. That means there's some fixed risk factors. And then there's certain things which we do to the patient in the perioperative period, right? Those are, you can mark it as a precipitating factor. That means some intervention was done, right? So, and in perioperative period, if you can divide the whole period into pre-op, intra-op, and post-op, then you have a defined 3 different segments. And we say, okay, in which area you have to kind of focus more, or which area risk factors or, features are coming more important in affecting the delirium, right? So, so with that background, if you start predicting, you don't want to make a prediction on one time, right? You want to make a prediction at any point of time to understand, when the delirium can happen, right? So that was one component of, like, because our perioperative period is, divided into multiple periods, and interventions can differ separately. The other thing which was very interesting to know and often overlooked even in the prediction model studies in understanding, that in prediction science, one thing is the time of prediction is very important, like when you are making prediction, right? So that's one. And number 2 is the prediction window is very important, which also get overlooked. That means you are making a prediction for the next 15 hours, next 24 hours, or next 96 hours. So it's the time of prediction and the prediction window. They both are very important features to define in when you're building prediction models. And in this study, we wanted to say that, okay, I want to predict delirium, let's say, at the end of the surgery for the next 24 hours. Or I want to predict delirium at 24 hours after the surgery for the next 48 hours. So and how do you devise a model which incorporates this complexity, right? And gives us answer, because those are the important questions, right? We don't want to just say, oh, this patient is high risk of delirium, right? So when, right? For how long? So those 2 components becomes very important. Now, in the static model, you are building a prediction in a one time period. Right now, let's say for any time period, and you have a prediction window of, let's say, 24 or 48 hours, right? So the mathematical model is like, okay, it calculates whatever it calculates for that time period. So that's a static model, right? And every time when you have to do a different time horizon or prediction window, you have to recalculate the whole thing, right? You can use multiple static model every minute, right? Keep on doing it, right? Or you can use a dynamic model, which is a single model, right? But in which any additional information can keep on getting added, right? And you can pick and choose whatever time, whenever you want to, right? So the math becomes different, right? And we said that, okay, if we do that, then it's one model which solves all the problem, and you just define the times. Now, in the dynamic models, we use landmark techniques. In landmark techniques, that means you define landmark time and you build you make prediction. So that was the reason of these two static and dynamic models, right? Because the variability which we wanted into when we want to predict and how long, plus we want to differentiate if preoperative information only if we use, if we add intraoperative information, right? And if I add postoperative information, if we keep on adding information, does our model, success improves? And so that is the other thing which we wanted to do, and we use different type of modelings for that. So I hope we try to put in detail in the paper regarding how we do. I would advise the readers to get into the paper and learn more about it, but always think about these two factors, like why it was done.
Right. I so agree. And thank you so much for explaining that. I think it makes perfect sense. And like you said, I think you did a phenomenal job explaining that in the journal as well. So readers can definitely follow through in terms of understanding this static versus dynamic relationship and model. Can you tell us, in your study, you identified various predisposing and precipitating factors for postoperative delirium. Could you discuss which factors emerged as the most significant predictors, and were there any unexpected findings that stood out during your analysis?
Yeah, so I think most of the work or the results which our study was kind of in support of the previous work or hypotheses, right? And so that was good, which is basically is the patient baseline characteristics. For example, their age, their disease, the baseline disease or comorbidity are important factor for delirium. Like a prior history of cognitive dysfunction, prior history of delirium are the biggest risk for any person to get a delirium, right? The common theories regarding exposure to opiates, and anesthetic drugs and everything, they have a very incremental increase in the chances of delirium. And if you look into our feature, I think that's, I believe, is figure table 4, in which the feature importance is there for the predictors. The duration of the surgery came out to be, very important in predicting. The amount of hypotension was also linked to delirium as a major risk factor. And actually, that was in our previous work, we have also linked hypotension is associated with delirium, right? So that was, as I said, so in a singular study, we were able to confirm a lot of different things which were there in the past. So baseline factors are the predominant thing, right? Then duration of the surgery, right? Amount of hypotension, some exposure to opiates are incremental, very small increments, which comes out to be in our study. And which is both good and bad, because we were hoping to find some modifiable risk factors so that we can, alter the course of the disease. And you can do a shorter surgery, you can wait a faster surgery. But I think longer surgeries function of the complexity of the surgery, right? So it is not, overall anesthetic exposure that needs to be seen. But besides hypotension improvement, right, limiting some opiates and everything, we didn't find any major kind of intervention which can be done to reduce delirium, which is modifiable. And I think that makes this whole field of cognitive dysfunction and delirium prevention wide open, and we need people like you to kind of research that and find cures for that, right? Because, we don't have an answer right now that how delirium should be prevented or how it can, or what we can do once it's happened, right? So for both.
Yes. And I agree. You have laid a great foundation for people like me to further research things like this so that we can find answers. Um, so, lastly, I want to ask, given the emphasis on baseline patient characteristics as major contributors to delirium incidence in your models, how do you envision the participated or the practical application of your findings in a clinical setting? And then after you tell me that, can you also elaborate on what steps or interventions could clinicians take based on the identified risk factors to potentially prevent or mitigate postoperative delirium in non-cardiac surgery patients?
Yeah. So the first of all, with regards to based on this finding, what we can do, right? So what we know is that baseline characteristics are the predominant risk factors for patient developing delirium, right? Um, and uh, and and perioperative, is very limited intervention which you can do, or modifiable factors which are there to reduce delirium. So there's few ways we can look into these findings. Number one, there's a role of uh, optimizing patient medical status before the surgery, right? We are in a rush for a lot of patients to go through the surgery. There's a role of prehabilitation in that, right? Optimizing, for example, diabetes care, or blood pressure management. I don't know. I mean, these are the things which we can think about, right? How we optimize the baseline function of the patient, right? So that's the one. Like, we should seriously think about, uh, you know, pre rehabilitation science, prehabilitation science, uh, and giving time for the patient to get to the best of his, you know, medical condition before going to the surgery. So that is the one thing, especially with respect to the delirium, right? Number two is basically few things like hypertension avoidance, limiting opiates,
Mhm.
and uh, now minimally invasive surgery, offering minimally invasive surgery to people who are at risk, because those are shorter surgeries, are options. Basically, you have to look into those options, that what are available and what you can do at that level.
Right.
So those are the things which can be done. And the third thing is, like, if we know a patient is a high risk of delirium, then you monitor them closely, right? Because at times what happens is that patient is on the floor and not monitored. They are, let's say, high risk of delirium. They get delirious. They trip, they fall, they get injured, right? They are not eating well, right? For example, and the poor nutrition intake otherwise, affect their outcomes. So the idea is that they they should be monitored closely, that, oh, this patient is a high risk for delirium. Let us do something. It's not a magic bullet here that you can give them that drug to prevent from delirium. Is that we know that we cannot prevent it, but at least we can monitor so that this so-called unintended consequences does not happen, like other injuries, right? So those are the three things which I believe where you can utilize this information. And the fourth is basically, we have to put more effort into figuring out how delirium happens. Delirium is are all different types, like hyperactive, hyperactive, which is more common. Which subpopulations is even more common? Like, this is broader non-cardiac surgery patients. And uh, what are the medical treatments which can be done, right? So, which opens up a huge uh, opportunity for research in this area.
So, again, thank you so much, Dr. Maheshwari. Your research and your findings have definitely influenced me and my opinion on the development and validation of delirium prediction models. I hope to continue to add on to this. Your research has brought awareness to a very important subject, and I'm very sure that you have influenced many anesthesiologists as well to consider these models in the future and expand on them. Thank you for taking the time to talk with me and allowing our audience to have a deeper and clearer understanding of this matter. To all the viewers and the listeners, please be sure to read the article in the Journal of Clinical Anesthesia May 2024 issue, and also be sure to follow our social media sites on X, formerly known as Twitter, Instagram, and Facebook at Journal of Clinical Anesthesia. Again, thank you so much, Dr. Maheshwari. I wish you and your team all the best.
Thank you for once again for having me. All the best to you. I do want to thank all the team. When you say it's your research, it's not it's our team's research, and everybody worked pretty hard on this project, especially Julian and Karan. So I would thank them. Yeah, it's a team effort, and hopefully you get interested into this field and start finding some cures for us.
Exactly. That is the plan. That is the goal. Well,
All
thank
right.
you so much. You have a great night.
Okay. Okay. Bye-bye.